this is an excellent question. The common thread behind all these three diseases, the low ejection fraction, so heart failure, pulmonary hypertension, and amyloidosis, is that there are diseases with very non-specific symptoms. Symptoms like fatigue, some dyspnea, some shortness of breath, that often trouble the clinician when the patient refers such symptoms. Is it something that is actionable that the clinician should evaluate further, or is it something that can be because of normal variation or because the patient didn't exercise as much in the last 6 months? In the current setting, the clinician that wants to evaluate further has to employ really invasive or complex tests, things like CTs, MRIs, even echoes, or even invasive things like right side cath. And as a result, the clinician often delays this, and we know this from academic medicine, that all three of these diseases, heart failure, amyloidosis, and pulmonary hypertension, are diagnosed at least 2 to 3 years later than what the beginning of the onset, than what they could have been. And a result of this is that you have worse prognosis for the patient and much higher cost for the system. What AI on a simple ECG can do is to detect and alert the clinician a lot earlier. What it is a very simple AI that runs into very complex AI, but operationally simple, that can run into a 12-lead ECG, a modality that is available everywhere, and immediately within seconds say whether such diseases are detected or non-detected. The accuracy of these tests is very high. It's much higher, for example, than in the metric of area under the curve, than well-accepted tests such as digital mammography or treadmill tests or BNP for heart failure. And it can alert the clinician about the existence of a disease, possible existence of disease, to guide the patient further into diagnosis and diagnosis sooner and treatment in much earlier stages of disease. The technology is very simple to actually practically use. It only requires a 12-lead ECG, and it only requires, as I said, a few seconds. A very low bandwidth. This is not a complex AI to run. It's very complex to develop, but not complex to run. The biggest opportunities is actually to make it available at the point of care everywhere in the United States and overseas. It is bringing the best of academic medicine at the remote primary care settings, and in a way that is simple, cost-effective, and actually practically reimbursed by the government and by the insurers. The biggest challenge of doing this are two. The one is simple awareness, and what you do today is actually helping reach out, make clinicians and patients aware that such a powerful tool exists. The second challenge is the practicality of deploying it into multiple settings. There is thousands of hospitals and tens of thousands of primary care clinics in the United States. A challenge that we are gradually overcoming through the work we are doing with our customers, the healthcare clinics, and to actually deploy it and make it available. When deployed, the technology is very simple. It's a button next to the ECG that runs the AI. It can even be available on the cardiograph machine, and that immediately provides the result to the clinician. Let me first give you a sense of the magnitude of the problem. Heart failure, low ejection fraction, it's such a widespread disease. There's more than 7 million Americans with it. Up to 40%, 38 to 40% of the first diagnosis of heart failure is actually performed in the emergency room. That means that the patient was completely unaware until the symptoms have been developed and have become so acute that the patient progressed to the emergency room. At that point, it's also very expensive. A heart failure hospitalization easily exceeds $20,000 in overall cost to the system. For pulmonary hypertension, the typical duration of symptoms is 2 to 3 years before a diagnosis is established. And for amyloidosis, it's also 2 to 3 years, and in some forms of amyloidosis, think that after diagnosis, the average length of survival of late diagnosis is less than 1 year. So this is very meaningful delays for the patient and for the system. Now, what evidence do we have that ECG AI can actually, or AI on the ECG can actually improve the treatment? One of them is the EAGLE trial. This is a 21,000 patient randomized study that was run in US primary care and randomized the primary care settings into those that did use and did not use AI, and had two very important findings. The first one was that the AI can help detect up to 1% more in the general population of heart failure. Think of it that the general prevalence of heart failure in the population is around 3%. So that's a very meaningful increase in the diagnosis of heart failure in completely asymptomatic adults. And very importantly, without increasing the downstream testing. In other words, the number of downstream echoes and subsequent exams that were done in the two setups were the same. For every John that actually got an echo sooner and got a diagnosis sooner, there was a Joe that didn't get a useless echo, a wasteful echo. And so that study, which was published in Nature Medicine, gives you a sense of how ECG AI can accelerate the diagnosis for the benefits of the patient and the system. There are similar examples from our development and our validation studies that show that pulmonary hypertension symptoms on the ECG develop between 2 and 5 years before the actual diagnosis, and in the case of amyloidosis, 2 to 3 years before the actual diagnosis. As long as the technology is there and available, it would lead to diagnosis sooner and to a better treatment for the patient and more cost-effective for the system. This is an excellent question. This is exactly where the rubber hits the road. It is the 12-lead ECG is ubiquitous. It's everywhere. It doesn't require complex skills to perform it, and it can be done in anywhere from the downtown Boston to rural Nebraska or any other rural setting in the United States. The way that we go about to make this available, there's two parts. One part is we work with our partners, the healthcare systems, to actually deploy it into their IT systems. So typically when the clinician orders an ECG in many of these integrated delivery networks, they go to a computer, they go to a screen, they order the ECG, and we work with them to make sure that the button is next to it, that they can order an ECG AI if they have a suspicion that the patient may require more advanced diagnostics. And that would make it immediately, as soon as the ECG is taken, immediately the AI is run on this ECG to provide the diagnosis to the clinician, whether these diseases, pulmonary hypertension, amyloidosis, or a low ejection fraction have been detected. We work with the systems, the healthcare systems, to also see how the technology practically is best deployed. For example, do we need a reminder to the clinician, or do we need to have any type of follow-up after a while to see that the echo was actually, or whatever the subsequent exam is, was actually ordered. The second thing that we are doing to ensure the deployment of the technology is to work with partners, technology partners in the field, machine ECG cardiographs that are actually make this technology available to more and more machines that are widely available in the United States, so that this can be done not only in the complex IT system, but also in the rural setting via cloud deployments. So these both are ways that we are investing to make this technology available. The key for us is awareness. We need to make sure that the clinician and the patient are aware, and once they are and they see how this technology can help them, it becomes a lot easier for us to deploy and respond to this demand. Our vision is to make the best of academic medicine available in the primary care and rural setting. Indeed, Anumana is committed in the further development of AI on the ECG, and we have multiple algorithms in late-stage development that we expect to roll out by the end of this year. so that we have algorithms that detect many primary care diseases in the cardiology setting. All of them will be deployed as a panel, meaning they will be run at the same time. Think of it like a blood panel where you can get the ECG and you can get AI on an ECG to detect or not detect multiple diseases. This will be for the same fixed price, so it will be all completely reimbursed. And we plan on rolling out the technology across the US as we're working with these partners. Our vision is to make the ECG AI a part of a routine care of the patient in a primary care setting in an annual checkup. This is something that will require additional work to show the cost effectiveness and the practicality, but we believe in the next 2 to 3 years there will be enough evidence that every time a patient goes to a clinician for an annual checkup, they would also take a 12-lead ECG and advance the cardiovascular care of that patient, regardless of where they reside. Even in the 46% of counties in the United States that have no cardiologist, the AI can offer the best of academic medicine to these patients and their primary care clinicians.